Hi, welcome to Two Shrinks and a Mic. I'm Dr. Andrew Rosen, psychologist.
And I'm Dr. David Gross, psychiatrist. And today we have the pleasure of a colleague of ours, Dr. Adam Demner, who is a psychiatrist with a specialty in addiction. So we thought it would be a good opportunity to continue with our discussion about substance abuse, to have him tell us more about what addiction psychiatry is all about. So Dr. Demner, welcome to Two Shrinks and a Mic.
Well, thanks for having me. It's a good opportunity to get the word out a little bit and clear up some of the misunderstandings about addiction treatment in general. And I think one of the kind of starting points would be the differences between addiction medicine and addiction psychiatry, because there's certainly a tremendous overlap, though as a psychiatrist, we look at the substance maybe a bit differently than purely within the medical model, meaning that there are factors that transcend the neurobiology. However, not paying any attention to them leaves you kind of handcuffed a bit. So it really is this intersection of the addiction, be it a substance or be it a kind of behavioral or process addiction like gambling, or even screen addiction is popping up big time. And how we understand that through the mind, not necessarily just the brain. I got into this field a while back primarily because it allowed me to practice my first specialty, which is medicine. And as a medical doctor, those early phases of really being able to pharmacologically stabilize and contain provides the framework and the possibility to kind of understand what's underneath. And it really is this back and forth balance, because oftentimes that substance is their most utilized and relied upon, sometimes the only coping mechanism. And it can be quite deleterious and harmful even to lift up underneath the rug as a therapist when the only coping mechanism is maladaptive and exquisitely harmful. In fact, back in the 70s, when psychoanalysis was one of the primary modalities and everybody was being fit into one box, they actually found an increase in alcohol use when they put people on the couch, which isn't incredibly surprising.
Yeah, I remember back because I was trained in psychoanalysis in the 70s, and the mindset when it came to people who were abusing or overusing or addicted to particularly alcohol at the time was get on the couch, we'll see you 3, 4, 5 times a week, and we'll figure it out. And once we figure it out, then the presumption would be that you would not any longer need your addictive substance. But in the process of analyzing and focusing on the disturbing parts of their life, they would often use the drug more to cope with the upset that they were getting from the understanding of what was causing their depression or their anxiety. And the guidance would just be, well, once we understand it, then you won't need your alcohol any longer, and that model never really worked. So, yeah, it's really like not only are you trying to take away the substance that they rely on, but then you may be aggravating things that make them need it even more. It's really a good point.
So you're not suggesting that putting somebody on the couch will drive them to drink? Well,
Depends how diverse their toolbox
Right.
is. Right?
as you're talking about the need to separate out the substance abuse addiction issue from the psychological stuff, it reminds me of challenges we have here in town. This is like the capital of rehabs. And, oftentimes I'll see somebody come into rehab where they'll pay good attention to the addiction, whether it's a 12-step approach or others. But somehow the psychological, psychiatric issues kind of fall through the cracks.
Yeah, it's very challenging because when one addresses the addiction without the psychological aspects or vice versa, it really leaves you kind of touching an elephant, kind of not seeing the big picture. And it really does require living in the gray and going back and forth and almost kind of going on the ride with the patient. Because if one overvalues the psychological conflicts, then much like Andy's saying, you see that uptick in the substance use. And our whole understanding of whether or not the substance is a symptom or the cause of symptoms oftentimes is an arbitrary question to be asking in the beginning, because the chicken becomes the egg and the cycle continues. And much like the theory of if we just understand it, then it'll go away. The question really is, why are we even asking? Not necessarily what's the answer. And it's this back and forth. You know, I think of it oftentimes like a child learning the monkey bars. Right? And they're going, and it's scary. If they look down, they're not going to move forward. If they look up, they get dizzy and they get disoriented. And if they let go before they grab onto something, they're going to fall. And similarly, if they grab onto something ahead but have difficulty letting go, they lose the momentum. And it's about really getting that grip without holding on too tight and sustaining the momentum. And sometimes it can be helpful to see and think about whether or not somebody is with a loose grip or no grip as to what lies ahead of them, and or that firm grip of holding back. But oftentimes they've got one arm on each monkey bar and just lost a little bit of the momentum.
It's tough work. I mean, you know, one of the things that my specialty has always been, or for most of my career, has been anxiety disorders. And one of the reasons I love it is because it's pretty easy to treat, you know. And I tell my patients, you're suffering with anxiety, but we know how to get you better. When it comes to addiction, it's not so simple, and there's different degrees of progress. And as you know, no matter what the methodology is the relapse rate is huge. How do you deal with that aspect in your work with relapse, or even not relapse, just no progress?
I always think that there's hope. Otherwise, I wouldn't
Right.
get up and do what I do. Somebody hits it out of the park on their first time at bat, fantastic. Though much of my time is spent in the batting cages. And it's being with that patient and helping them find a safe space to look into the mirror that I hold up for them to better come to these conclusions, these thoughts on their own. Because, I mean, if Nancy Reagan's approach worked, then just say no would have made it so I didn't have a specialty. And I'd be happy if that were the case. I'd go figure out something else to do. But that's just not that simple. Right. So it really is, in part, containing that ups and downs along with the patient and helping them see that a step back doesn't mean that they have found a new rock bottom.
Now, I guess the other challenge that I see all the time, in fact, I saw it this week with a young man I saw, is the fact that when we treat depression, anxiety, panic disorder, people don't want to hold on to those disorders. They're more than happy to get rid of it. But when it comes to substance use issues, that's a devil. I mean, I saw somebody this week who clearly needs to be on medications for attention deficit disorder and to deal with past trauma, a lot of psychological issues that need to be addressed, had a significant substance problem in the past, went to rehab, spent months to get clean, except started drinking again and still uses marijuana fairly regularly. And I tried to explain to this individual that you're making my job almost impossible. But that's the problem. And I'm sure for you, it's a major challenge to deal with that resistance and the denial and all the other aspects of addiction.
It is. And kind of the approach that I take therapeutically really depends upon where they're at in something we call the stages of change, which is a nice framework and model, and kind of branches off in a way from more of the cognitive behavioral therapies, specifically within motivational enhancement therapy, where we think of it as kind of pre-contemplation, where, there's no problem. I'm not even thinking about it. And then they get into kind of what I think of as that circle of change, where they're thinking about it, but they're not so sure. And then it goes from kind of the thoughts about it to planning on what to do about it, which transitions to putting that to action, and then the challenge of maintenance and keeping that going. And within the stage of change, to your point, Andy, is the relapse aspect. And that's to be understood as potential and part of it. And when someone's in that relapse phase or the pre-contemplative phase, the main goal is to really work within a CBT-like framework to get them into the circle.
And stay in it.
And stay in it. And that's where early on, looking at things through the lens of permission-granting beliefs or addictive beliefs. For example, I had a really rough day. I deserve a drink. Right. Or I haven't touched any meth for 3 months. I deserve it. And similarly, as you're alluding to, David, that idea of kind of returning to use, and I need a little bit extra Xanax in order to function. And when one has those experiences throughout the life, they're not necessarily aware of it at the cortical level. And it really is hijacking the neurobiological reward pathway. So that's where kind of the neuroscience meets the couch, so to speak.
You know, we talked about this in different ways when it comes to people. Just the other day, there was a gentleman said, I'm feeling much better now on the medicine, so maybe I don't need it any longer. And, very often people on their own, they go, I'm going to stop because I feel better now. And the same thing with therapy. It's like, they start, the crisis is over, the really bad phase is over, so it's, I'm okay now, I can stop. And with substances, it's the same thing. I'm doing pretty well now. I'll just use it intermittently, as a reward, even now that I don't need it. And then, of course, the relapse occurs. So at all stages, it's really tough work. Getting somebody on board, tough. Keeping them on board, tough. And then the long term, it's because it is a lifelong struggle. So it could be 5 years later, I deserve that, whatever. It's, it's a lifelong dilemma.
Think of it almost as throwing out an umbrella in the middle of the rainstorm because you're dry. And then
it's a good one.
Being curious as to how you got soaking wet.
Right. And then there's the issue of the people who go into rehab. What percentage really want to be in rehab?
Right.
It reminds me years ago, we had an adolescent unit in the hospital. It was not a substance unit. It was regular psychiatric. And my job was to interview the adolescents when they came in, because I was clinical director, and to interview them when they were discharged. So when I interviewed them in the beginning, they were furious and PO'd, and I didn't want to be here, and it's against my will, and all that kind of stuff. But at the end, in those days, they could stay for a month or two. And in the end, they all said, I realized I needed to be here. And that's the problem in a lot of recovery. They have the 28-day model, which is based upon insurance more than anything else. And, you really don't wonder how many people really get it if they didn't want to be in the first place, and it's 28 days long enough to finally get to it. And one of the best programs in town does better, I think, because they're supported by United Way and don't have to depend upon insurance. And they keep people for 2, 3, 4 months, if need be. And by that time, you're able to deal with, one, my brain's clear, and two, you can deal with those issues you're talking about that are more psychologically based. And they do much better. But unfortunately, we've got a different world now where the insurance often really describes what kind of treatment they get.
It's unfortunate because the evidence and the science there supports precisely what you're saying. And the motivation for getting into treatment is surprisingly less important than being in treatment, right? And we see this a lot with the more rigid professional organizations that help impaired individuals, be it pilots or physicians, where there is that close monitoring and the attention to it and the unique tailoring for the individual. Because once they're in the program, and they certainly don't necessarily want to be, they get better. And it kind of establishes this external locus of control that they've been receiving in a lot of ways from the substance. And that takes time because, in part, the neurobiological aspects, that things are very much disrupted and kind of set in this conditioning way, almost like a rat pressing a lever. And it takes some time for the receptors to recalibrate, so to speak.
But you're leaving out the stick aspect of the carrot and stick model for physicians or even attorneys, because about 5-10 years ago, I saw the data on the local Florida program, which is called the PRN. And they have the highest recovery percentage of any treatment program in the state of Florida. Why? Because the physician signs a contract that says, if I don't do the 5-year program,
You're out.
I'm losing my license.
And that leads into kind of the concept of empathic coercion, right? And early on, it's less about finding insight as it is about finding what the individual is looking for and being able to help with where one might get some leverage, right? Oftentimes, more often than not, parents want to support, but they don't want to enable. And they also don't want to abandon. And finding that sweet spot within each family is where a lot of the dynamics come into play.
I always find it interesting if you think about this, and I use this as an analogy with people who are cigarette smoking. Person decides, I want to quit smoking, and they take X number of days, they've been successful, but they know right around the corner they could get in their car and go get a pack of cigarettes. But I say, if you lived on an island where there were no cigarettes, no nicotine, it doesn't have any presence on that island or in that country, and you knew to get off the island to go get cigarettes would be like a 3-day journey, your cravings would die very quickly because of the lack of access, and you just can't. So the back and forth indecision, should I, shouldn't I, doesn't exist. And I think that's what works with PRN, is that I can't. The consequence is so great that even if it's right in front of me, I don't think I'm going to be able to do it. But in most cases, everything else is available. And what I wanted to ask you is if you're finding in our culture today where, well, just the other day, a kid said to me, he finished his first year of college and he's on medicine and he's doing much better with his OCD. But he said, what do you think about, the psychedelics? And I said, well, there's early research, but it don't. He said, well, I tried it a couple of times already, and it was kind of nice. And so in our culture, you're hearing about, well, psychedelics may be good. And then you're hearing about marijuana is pretty good. And then you're hearing about all kinds of substances that have become normalized in our culture. how are you finding that in terms of dealing with patients who, are on the path?
I'm finding it increasingly challenging to compete with Dr. Google is one thing,
Right.
but Dr. Podcast Gurus is another.
Right.
And now more and more Dr. Chatbot, right? And what people fail, I think, to fully recognize is that reading someone's opinion and adopting it as your own is not research. In fact, researchers study how to research. That's what they do. And with the amount of information that's out there, and by the time it gets diluted through other people's opinions and presented as fact, it's incredibly misleading. And as it pertains to psychedelics, we saw this happen in the 50s and 60s when these agents were first discovered, and it kind of got out of the lab in a way. Right. And because of a lot of cultural influences, be it where one is geographically located or be it the political landscape, it was ultimately scheduled and the research disappeared up until the resurgence recently, in which the most robust research came out of the elimination pretty much of anxiety in those with terminal cancer. And that really paved the way for more research being done. But what I'm most concerned about is, first and foremost, people never know exactly what they're taking. In the research study, they got it down to a science, literally. And the terms microdosing are all relative. Yeah. And people don't even know if what they're taking is, in fact, psilocybin or psilocin, which is what's being utilized in these studies. There are countless synthetics out there, and it doesn't do the same thing. But what concerns me most is that you've got a cohort of people that are searching for answers. Right. And either they've tried everything and it hasn't worked, or they're looking for a shortcut. And in doing so, it can be very dangerous to disintegrate the ego and further fragment somebody who's already confused and leave it up to themselves to put it back together. Now, this is, in a way, what psychotherapy in the long term does from a psychodynamic approach, is take a look at who am I? And that tends to be titrated over years.
And that's the challenge, because everybody's looking for that shortcut. I'd love it if people are looking for answers. That would be healthier. But everybody's looking for the quick fix and the shortcuts, and to get people to understand that it's going to take time. And then to get them to say, well, you may need to get involved in AA or NA in addition to the other work that you're doing. People want it better tomorrow.
The thing is, in our culture, and a lot of it has been gradual and even just in general medicine, we've learned to, if something's wrong with us, take something, put it inside, swallow it, put it inside, and in X amount of minutes or days or weeks, you'll feel better. And that's, in general, it's been going on for years and years and years. And then, I think with the good news in our field is that we're talking much more than ever about the actual brain and the chemicals, but that also kind of seeps into the culture, which is like, well, I just have to find the right thing to take. And then, well, there's the ones that these shrinks give us, and then there's the ones that are out there that they don't want to tell us about, the marijuana, the psilocybin, the other things that are available I can get on my own at a dispensary. So it's complicated, and it's getting harder to deal with the issue that really it's not a quick fix. It's not all chemical. We need to work through things too.
And then, of course, you've got to get the family involved, because half the time the substance problem came out of the family dynamics, the family situation. You know, I remember in the early days, Betty Ford used to bring in the whole family to their inpatient unit, not just the individual person who had the drug problem, because they had to address. And some of the big bands, I heard a story that I think it was from a hospital in New Jersey where not only did they admit the players of the band, but they admitted the manager as well, who
Who's
made
usually
sure
the one supplying it.
they gave them the money so they can get the drugs. So it becomes very, very complicated. And
Yeah, that's something referred to as family network therapy, where unlike family therapy, where every individual is a patient in service of the unit, it looks at the unit in service of the patient. And it helps define those boundaries. And oftentimes it's the process of figuring out where those boundaries are that leads to the benefit rather than where the boundaries are ultimately drawn.
It's the process.
And then, you know, you're getting back to the concept of fellowship in AA and how people suddenly find themselves surrounded by individuals who care, where they share similar experiences. And, you know, it's not a pure psychological model for sure, but you get a sponsor who can be there for you and turn things around. And
It's tremendous. And I don't have the stats on it. And in a way, because I don't, is why I think it works the way it does. Because people are going to get different needs met from different relationships. And I'm not a sponsor, but I do implement 12-step facilitation. Sure. I don't work the steps with patients, though I know what the steps are.
But you don't need to.
Exactly. What I can do is get a sense of maybe if that momentum slowed down a little bit on any given step, and again, hold up a mirror and let the patient see that. And oftentimes they'll reach out to their networks. And a lot of times that resistance of walking in the room and being judged has been facilitated in a way, notwithstanding all the difficulties of virtual care, but allowing a little bit of anonymity to enter one's first room so they can realize, wait, that's what I was so scared about? That was nothing. That has really opened it up. So being able to think outside the box, and at the end of the day, don't treat diagnoses, like treat humans.
Right.
Good comment.
Big issue, big point.
Well, it's been a pleasure having you here. I think it's been illuminating, and hopefully it's been helpful for the audience as well.
Yeah.
No, thanks for having me, and if questions come up in the future, I'd be happy to come on back.
Great. Good to have you here. Thank you.
Thank you.
And I'm Dr. David Gross, psychiatrist.
And I'm Dr. Andrew Rosen, psychologist, and thank you for being here at Two Shrinks and a Mic.
Bye-bye.
The Two Shrinks and a Mic podcast is for informational and entertainment purposes only. The views expressed are those of the hosts and guests and do not constitute medical, legal, or professional advice.
Please always consult a qualified healthcare provider before making any medical or wellness decisions. Our content is not a substitute for professional medical guidance, even though our mothers tell us we have the best advice possible.